Hello, everybody. Today we will be talking about pericardial effusions and then cardiac tamponade. What are the signs of the cardiac tamponade on echocardiography? And we will briefly discuss different clinical scenarios and why it is important to identify effusions and also the signs of the tamponade, especially in ICU settings, because I think you will see a lot of pericardial effusions in ICU, especially when the people are kind of sicker, right? And then we should know or to check the signs, and we should know the etiologic factors of the pericardial effusions. So let's get started. So the first thing, I just wanted to put this slide here. I'm not going to discuss these details, but we should know the etiologic factors for the pericardial effusion is pretty much like everything. So a lot of things can give you pericardial effusion, including infections. It can be viruses, bacteria, fungus, parasites, and it can come from the malignancies, traumas, autoimmune diseases, medications, probably uremia, thyroid disease, and so on and so on, right? So that's the purpose of this slide. I just want you to keep in your mind that fusions can come from many different conditions. Okay, so it means that you will see that frequently in ICU, and you should be able to kind of correlate your findings with your clinical symptoms. Okay, so let's get started. And first, we should like identify pericardial effusions, and we should know where it is, and we should know that the pericardial effusion can be associated with other types of effusions too, right? So in this slide on this video, you can see that there's a pericardial effusion here. There's like big black thing here, which actually represents some kind of effusion too, right? So what is this effusion here? And this is pleural effusion, right? And the best orientation marker we usually use is descending aorta here, okay? So if you have this descending aorta here, and if you follow that, you can see this pericardium layer, and then above that, it's going to be pericardial effusion, and below that, it's going to be pleural effusion, right? So it's very important to know about this, and you should be able to identify descending aorta. Most of the times, if you have the Parsonal long axis view, you will always see descending aorta, and then you can identify your effusions, because we know that the management of these two conditions are completely different, and then also like, sometimes we should decide if patients require invasive intervention or no, and we don't want to make any mistakes while we are assessing effusions using echocardiography. Okay, so it's very important thing, and it's very important to identify effusion. This is the slide I found on internet, and I think that's a great slide, very informative, but I think it requires a little bit of explanation of the echocardiographic signs of cardiac tamponade, and we have a lot of information here, and I wanted to spend some time on this. So let's do that. First thing here we see is the size of the effusion, and then we call that it's small when it's like less than 10 millimeters, and we call effusion is large if we have more than 20 millimeters here. But I put in some question here, right? Which is more dangerous, if we have 400 milliliters of the fluid in the pericardium, or if is it more dangerous if we have 1200 mLs? I think it seems like 1200 is kind of worse, but in general, in pericardial effusion, it's more important to assess the rate of the accumulation rather than size, okay? So it's more kind of crucial if effusion develops acutely in maybe day or two, because actually if you have 400 mLs developed in like day or two, you will get cardiac tamponade acutely, because you don't have time to stretch your pericardium, and you don't have time to accumulate this fluid in the pericardial sac. Because if you have some kind of chronic problems like malignancy, autoimmune diseases, maybe chronic kidney disease and renal failure, and at the end you have like end-stage renal disease, and then you have like slowly accumulating pericardial effusion, it actually can stretch out significantly, and I've seen like 1500, 1700 mLs drained, but they never cause tamponade, okay? So here you should remember that the rate of the accumulation is more important than the size, okay? You might have large pericardial effusion, but it can never like cause tamponade. Okay, so it's important thing to remember. Another very important thing is the chamber collapse, and you should see here that we have right atrial systolic collapse, and we have right ventricular diastolic collapse. And why systolic, why diastolic? It all comes from normal physiology, and we remember that the right atrium kicks when ventricle is resting, right? When the ventricle is in the diastole. So in systole of the ventricle, technically right atrium is filling up, right? So that's why if you have right atrial systolic collapse, it means that you are not filling up your right atrium. So it means that you're decreasing your emptying of your blood towards the right ventricle because you don't have that blood already in your right atrium. So if it's collapsing at the time, it's very bad sign, right? Because we know that filling of the RV goes down, eventually stroke volume coming down, and also cardiac output is decreasing. So it means that patients probably will get hypotensive too. And same principle applies here in right ventricle diastolic collapse, because we know during diastole, ventricle should be filled up by the blood, right? But if during diastole, all this effusion is compressing the ventricle, you cannot fill it up. So same circle will happen, right? You don't fill up your ventricle, it means that you have low stroke volume and low cardiac output, so you have some hemodynamic compromise. So this is very important thing to remember, and remember that the atrium technically contracts during ventricular diastole, and that's why we call it, if we have ventricular systole and at the same time we cannot fill up right atrium, it can give us hemodynamic compromise. Okay, and we have here, of course, if you have some kind of left-sided compromise, it means that the pressure is so high compressing your left ventricle, left atrium, it probably already compressed your right side of the heart as well, so it's not a good sign. And we have swinging heart, and it kind of correlates with the QRS complexes on the EKG. And we remember from the med school, I guess, that we have a condition called electrical alternance, when we have this different amplitude of the QRS complexes because heart is like swinging around back and forth. So it kind of gives a different recording on the EKG. And another important feature I wanted to say is paradoxical septal movement, which means that imagine you have like pericardial effusion and you are kind of taking a breath, and we know that during inspiration we are increasing our preload, so we should fill up our ventricle, but effusion is kind of provides hydraulic pressure on your right ventricle, so it prevents the filling, right? So all these blood should go somewhere else. So what happens is that these large amount of blood in your right ventricle bowing and pressing your septum, so it pushes the septum towards the left ventricle. So it means that you are creating technically left ventricular filling problem and eventually left ventricular outflow tract obstruction. Okay, so imagine that you're taking a breath and your left ventricular outflow is kind of going down. It means that your stroke volume is going down and your cardiac outflow is going down. And that's what we call pulsus paradoxus, right? You're taking breath and your pulse is disappearing because your stroke volume is going down at the time. So that's, I think, very easy to imagine, and I have one slide to show you later to really kind of imagine how it works and what's going on there. And the name we call that is ventricular interdependence. Okay, so it means that ventricles depend on each other, depend on each other's fillings, right? And if you have stretching of the right ventricle, it will technically push your septum towards the LV, and it will give you some kind of changes in your LV, right? So that's why we call this ventricular interdependence. And imagine we have all these changes, in the flow during inspiration and expiration. We should be able to identify all these things on our echo machines, right? So we can see all this change of the flow pattern on the on our Doppler, right? So if you put like pulse wave Doppler on mitral valve or on tricuspid valve, we should see respirophasic variation. So we should see the filling is going up at some point, which is going to be expiration, and then filling is going down during inspiration, and vice versa, right? And the mitral, if you see the opposite side of the heart. And let's go and check that on the next slide. Here we have here like it's kind of the graphical representation during expiration here, and during inspiration what's going on. I kind of described it already. So in inspiration we know that we have a lot of like preload, a lot of blood going towards the right ventricle, and then it should technically expand here outside, right? Because we remember all this Frank-Starling mechanism, it will stretch and then it will pump this blood out, right? But imagine you have all this effusion here preventing the expansion. It means that all this blood will press your left ventricle here, and it bows your septum towards the left ventricle. So every inspiration results decrease in your filling of the left ventricle and eventually stroke volume, right? That's why when we check pulse, disappears during inspiration. And if you listen to it with your stethoscope, when you are measuring your blood pressure manually, you can appreciate that the sounds disappear during inspiration. That's why it's called pulsus paradoxus, because it paradoxically disappears. Okay, and that's, I think, easy to imagine. And I mentioned on echo, how can we identify? And you can see all these flow patterns here, right? This is your flow here. During inspiration, you see how small it becomes, right? And then we see here that is again goes up and then again goes down. So it's like cyclic, right? We know during inspiration, a lot of blood coming in, then we don't have room, so actually filling is impaired. So all these changes in the filling pressures because of the effusion, which provides extra pressure from outside, is preventing this filling, and it's respirophasic, right? We know that it's related to the inspiration and expiration. So it's very important to, kind of imagine physiology, what's going on, and then I think it's easy to understand why do we have these kind of changes in our flow pattern. So that's gonna be your sign of tamponade. And you should also recall a few things, right? When you see the pulsus paradoxus finding, so this is your pulsus paradoxus, right? We know that the flow and filling is changing, so your stroke volume is going to be different too in every inspiration, right? In every breath you take. So, and you should remember, it's not only cardiac tamponade. We know that during severe asthma, maybe severe COPD, it can give you pulsus paradoxus as well with the same mechanism, right? There is no tamponade, but we know that in severe asthma, intrathoracic pressure is so high, it technically increases your afterload for your right ventricle. So all this blood, instead of going towards the pulmonary artery, actually pushing your septum, right? So it's exactly the same mechanism. It pushes your septum towards the left ventricle, so your stroke volume goes down, and that's why you can see pulsus paradoxus also in other respiratory like diseases. Okay, so that's why it's important to know. And I kind of mentioned ventricular interdependence, and that's when we talk about like when the septum is like pushed away towards the LV. And on this video, you can see during inspiration here, septum is kind of fluttering. So it's like very clear that during inspiration, your ventricle is pushed towards the your septum is pushed towards the left ventricle, which impairs your stroke volume, and that's going to be your pulsus paradoxus. Okay. And this is your stringing heart here, okay? And it's kind of pretty obvious. There's a large effusion, and we see right atrium is collapsing here, right? Here you can see this wall on this side. It's significant collapse of your right atrium, which means that you're gonna have right atrial systolic collapse, so it cannot fill up, and it can eventually cannot provide adequate filling pressures and filling volume to the right ventricle, so you will have low stroke volumes and cardiac output as a consequence, okay? And here on the EKG, this is a real patient I had during residency, and we identified on the bedside, and he also had this electrical alternance. You can see different QRS complexes in terms of the amplitude, okay? So I think it's very obvious what we are talking about. Sometimes we can see more than just a effusion, right? So on these slides, you can see on the left, there's a big effusion, but there's some kind of mass, right? You can see here, there's a mass, so it's metastatic lesion, and you can see as well here, small mass, so probably this effusion comes from the malignancy, right? It's a metastatic lesion in your pericardium, so it's pretty obvious to see. And another case here, it's not like simple effusion, right? You see a lot of septations, you see a lot of fibrinous material there, so it will guide your management as well, right? Maybe just a simple pericardiocentesis is not enough, and maybe you're gonna leave the drain there, or maybe you need to take out the pericardium, right, and do the pericardiectomy, right? So all this information is very easy to obtain with the ultrasound, and I think it will change the management plan as well. And on the next slide, we can appreciate one important clinical scenario. Imagine you have the patient with hypertensive crisis, chest pain radiating to the back. You did your bedside ultrasound, and you see this is what's going on, right? So are you gonna be concerned Definitely, right? Because you have suspicion for aortic dissection, you're putting your probe on the patient's chest and you see some kind of pericardial effusion. So you are worried about type A dissection, right? So that's going to be emergent reason to call your cardiothoracic surgeons, right? So it's important to do that. It's important to identify the signs of tamponade. And it's also, I think, clinically changes sometimes a lot of things, right? And besides that, you have the patient in the shock state, you should know if there's any component of the obstructive shock, right? Which is going to be tamponade in this case. And that's it for today. Thank you and good luck.